In part two of integumentary disorders, we're actually going to look at some specific skin conditions. Before we go there, let's talk just a little bit about health promotion, because an ounce of prevention is worth a pound of cure. We know that sun exposure, particularly exposure to the UV rays, either from the sun or what I like to call tanning coffins, puts a person at risk for skin disorders, in particular skin cancer, malignant melanoma. So some things to keep in mind: limiting exposure to the sun, particularly between the hours of 10 a.m. and 2 p.m., which is when the sun is most direct coming down. Using protective clothing or wearing long sleeve clothing covering the skin, and also the use of sunscreens to help block some of those UV rays. Now, it is important when you're talking about sunscreen to make sure you're using an appropriate SPF, as well as to reapply the sunscreen periodically. And for it to be most effective, sunscreen should actually be applied at least 20 minutes before going out into the sun, and typically reapplied every hour to 2 hours, perhaps even more often if you're in the water and it's washing off or you're really sweating. Photosensitivity is also something to think about. This is when a patient is particularly sensitive to UV rays and can develop a sunburn-like skin reaction. Many medications cause photosensitivity as a side effect, so it's important that your patients know that and be taught that if they're on a medication like that, as well as how to protect themselves. Again, avoiding exposure to the sunlight, wearing appropriate protective clothing and sunscreen. Also, rest and exercise and overall good nutrition is important for skin health and just overall health in general. You need vitamin A, you need vitamin C, D, and E to help provide the building blocks to maintain the skin and the cells. So keeping in mind that those things are very important. Hygiene. There are natural, normal flora that are on our skin. There are healthy bacteria that are on our skin. There's also harmful bacteria that are on our skin, but it's kept in check because of the typical healthy, normal flora. However, hygiene is recommended, okay? Mild soaps. Use of antibacterial soap is actually not recommended because it messes up that normal flora. You do want to wash often enough that you remove excess oil and excretions, but not too often that you're actually drying out the skin. It's recommended that moisturizers be used immediately after the bath and shower to seal in that moisture. I mentioned nutrition a little bit before. Your vitamins, your proteins, unsaturated fatty acids, all of those are extremely important in maintaining the building blocks that your body needs to keep a healthy, intact skin. So when we talk about skin conditions, there's some overall goals and objectives we're trying to achieve. Certainly we want to prevent any additional damage. A lot of times these skin conditions can cause itching, which then leads to your patient scratching, and then they can scratch open an area in the skin. It's a portal of entry, and then you have the infection that sets in, and it's just a vicious cycle. So we want to prevent additional damage. We want to prevent secondary infection. We want to reverse the inflammatory process and really relieve their symptoms. Those are kind of our overall goals here. We want to maintain skin integrity, relieve discomfort, promote sleep, again for your more chronic conditions, helping your patient work towards self-acceptance, knowledge on how to care for themselves, and avoiding complications. So let's start with pruritus, which is just intense generalized itching. Lots of different causes. This is a symptom. It's not really a disorder in and of itself. It's a symptom. But it's associated with a lot of medications as a side effect, reactions to soaps, chemicals, radiation treatment for cancer, external radiation can cause pruritus, contact with fabrics, even stress can cause this. It is definitely more common in our elderly population because their skin is drier. They also tend to have systemic illness, and also it's associated with polypharmacy. Again, common side effect of certain medications. And when you have a patient who's on multiple medications, that increases the risk even more. Anyway, the itching itself is annoying. It causes your patients to scratch. When they scratch, it releases histamine, which causes more pruritus. We call this the itch-scratch cycle. And it can result in infection, and it can actually cause pigment changes in the skin. The symptoms tend to be worse at night, at hour of sleep, which can really interfere with your patient's, sleep-rest cycle. We also have skin infections. Now, again, remember I mentioned there are normal flora on your skin, and most of the time it's perfectly fine. MRSA, you've all heard of MRSA. Probably if I swabbed the class, 75% of you would have MRSA somewhere either on or in your body. It's not actively causing a problem because your immune system is keeping it in check, or especially if it's residing on your skin, it's not inside the body, it's not causing a problem. But when there's a portal of entry that allows it to get in there, or your immune system's already taxed with a primary infection, a secondary infection can take hold. So as you're looking at skin infections, hygiene's really important. Infection control practices are really important that, one, we always think of not spreading from patient to patient, but even on a single patient, not spreading it to different areas of the body. So when you kind of take a look at the pictures, the foot up there that has some redness on there, that's cellulitis. The one right next to it with the lips, the lesions right above the lip, that's considered herpes 1, or your common cold sore. Your little girl there with her little crusty nose, that's impetigo. Coming down to the bottom on the left side, that's candida, so that's like a yeast infection buildup right there. Number 5, those gnarly looking toenails there, onychomycosis, so that's an infection underneath the toenails. And finally, our elderly patient over on the side, that is a pretty significant case of facial shingles. But all of those are considered different types of skin infections. Moving on to something that makes us all itch, probably, skin infestations. The actual itching and the swelling and the lesions that develop, it's actually a result of the allergy to the venom or a reaction to the eggs, feces, or the organism itself. With infestations, prevention is really the key. Whether we're talking about mosquitoes, whether we're talking about chiggers, whether we're talking about scabies, anything like that. If it's an outdoor thing, insect repellent, ticks, things like that is really, really important. So trying to repel it from, happening. Body hygiene and cleanliness of personal items. You want to avoid sharing personal items, avoid sharing hats, scarves. That's usually, we talk about lice in the school-age children, and it's probably one of the most common things that you see. And contrary to public belief, it's not a dirty disease. It's actually much more difficult for the lice and the nits to stick to greasy hair than it is to clean hair. But just kind of keeping in mind hygiene and cleanliness, and it's really about reducing the spread. When we talk about cases where people have recurrent infestations, it's usually because the original infestation was never cleared 100%. Or maybe it was cleared from the body, but if we didn't treat the environment, they're just going to get reinfested. Okay. Treatment for these infestations, usually it's permethrin. I know there's a lot of old school, over-the-counter internet remedies. We are starting to see bugs that are a little bit more resistant to some of the over-the-counter stuff, so sometimes it may even take some prescription medication, but it's really about being diligent, not only with the treatment and following through with the treatment, but also treating the environment as well. Otherwise, you're just going to have a reinfestation. Looking at psoriasis, this is actually an autoimmune inflammatory condition. It is chronic. So your patient will have periods of remission where they're doing fine and they're not having symptoms, and then they'll have flare-ups or exacerbations where you start seeing the actual skin symptoms. Those exacerbations are usually stem from stress, trauma. It can be seasonal. It might also be hormone related as well. We do typically see that particularly in adolescent and young adult females. Best way to deal with this is looking at trying to remove the scales as much as possible during the bath. You want to kind of have them soak and soften a little bit. Use a soft brush to kind of get off the scales as much as possible. They'll use emollient creams after that, and basically you're maintaining a routine. In severe cases, we may need to use some pharmacologic therapy. They'll start with topical therapy, so it could be a lotion, a powder, cream, gel, paste, whatever. You do have to understand with using those, you want to make sure the skin is cleaned prior to that. For ointments, creams, and lotions, you want a thin layer spread evenly. If it's a paste, that's going to be a more thick layer that you apply with a tongue blade or a gloved hand. But again, that skin, that area has to be cleaned ahead of time. Sometimes your topical treatments aren't enough, and we use medications systemically, whether it's an oral medication or sometimes it's an IV medication, but it's administered and the medication goes throughout the body. We're treating it systemically. In some cases, they will use phototherapy where they use IV and laser rays to actually treat the different lesions. I do have psychosocial considerations up there because when you have a disorder such as this, particularly if it affects the neck, the hands, and the face area, patients can be very, very self-conscious with that. So that is something you need to consider. So just looking at some general care related to skin conditions, hand hygiene is going to be really important, making sure we're not, exposing the area to any additional bacteria, microbes, any type of secondary infection. Using PPE as appropriate. Things that will help with the itching, the pruritus, you want to avoid situations that are going to cause vasodilation, because that actually is going to exacerbate the itching. So things that can cause vasodilation, hot temperatures, ingestion of alcohol, ingestion of hot foods or hot liquids. It just kind of causes that vasodilation and it enhances that itching, which then will cause the scratching, and we just have that whole vicious cycle. Cool environments are very helpful. Again, a cool environment can cause vasoconstriction. It will reduce sweating, which should help with those symptoms because that perspiration is going to irritate it. Humidifiers, so adding some humidification to the air can be very helpful with that. Certainly overall hygiene, you want to avoid excessive amounts of bacteria on there, and trimming the nails and keeping the nails clean is going to be very important. Again, if they're trimmed, hopefully they're not causing damage if they're scratching or rubbing that skin. And certainly if we're cleaning underneath the nails, we're going to try to get rid of some of that bacteria that, if given the opportunity to get into the body through a portal of entry, can cause a problem. Pharmacological therapy, I kind of mentioned this a little bit before, but corticosteroids are commonly used. They suppress the immune system. They suppress inflammation. So we see these used topically. They might be used what we call intralesional, so it's injected actually into the lesion, or systemic through oral or IV medication. Typically, again, we're looking for anti-inflammatory. This should help reduce the itching, mask those clinical manifestations. Something to kind of keep in mind if they are on these medications for a long period of time, not so much topical, but if they're on systemic corticosteroids for a longer period of time, it actually does suppress the adrenal glands, which can cause a problem when they eventually come off this medication. Antibiotics are used topically and systemically if there's infection suspected. Antihistamines such as Benadryl or Atarax, those can be given orally or systemic. These are really aimed at reducing the symptoms of the pruritus, reducing the itching. They often do have some sedative effects. So from a safety perspective, you want to watch your patient, especially till you know how they react to these, how their body's going to tolerate it. Immunomodulators, these are used particularly for things like psoriasis, which is the chronic inflammatory condition. But these are used to try to modify the immune system, kind of suppress that overactive immune system. These are typically applied topically. It tends to cause some burning initially at the application site. Long term, it could potentially increase the risk of skin cancer. So you're always looking at a benefit versus a risk for each individual patient there. For wound care and dressings, talking a little bit about therapeutic baths. This is appropriate for large body areas. And when I think about this, I always think about like the kids that got chicken pox really, really bad when I was little. And they'd be in that, calamine lotion, oatmeal bath type thing to help kind of relieve the symptoms. Something to keep in mind after the bath is finished, you want to very gently pat the areas dry. You don't want to rub the area or that's just going to cause more irritation. Occlusive dressings are commonly used to cover topical medications. Those should not be left in place greater than 12 hours. That's a really big consideration because if they are, it can actually cause more damage to the skin than good. Other dressings we commonly use are what we call moisture retentive dressings. If you talk to seasoned nurses, you would hear us talk about wet to dry dressings. Now we don't want it sopping wet. We don't want it to get completely dry because that actually we found does not really help with wound healing. So now we want to have a little bit of moisture in there to help promote healing. Wound care is very much like Goldilocks and the Three Bears. If the wound is too wet, it's not going to heal. If it's too dry, it's not going to heal. It has to be just right. So your moisture retentive dressings, typically they'll have normal saline in them. They might even have additional additives such as zinc or other antimicrobials, colloidal silver, so it avoids maceration of the surrounding skin. Typically, these dressings are changed once a day or twice a day. In some cases, they have some commercial ones that can stay on up to 1 week. So things like hydrogel dressings, hydrocolloid dressings, foam dressings, your calcium alginate dressings, those are all considered moisture retentive dressings. So we're going to move to skin cancer, which is the most commonly diagnosed malignant condition. Okay, risk factors for skin cancer, those with fair skin, very light colored skin, and those with red hair we know are at higher risk. Those who like chronic sun and UV exposure, whether it's laying on the beach or in our good old tanning coffins. If there's a family history of skin cancer, any type of exposure to tar and chemicals. Outdoor occupations, people that work outside all the time, again, just simply because they're exposed to that UV light consistently, and smoking. So when we talk about skin cancer, early detection is really the key. So just like we talk about monthly breast self-exams or monthly testicular self-exams, as a person, you should be doing and teaching your patients to look at their bodies every month, okay? And looking for changes. And really part of the yearly physical exam should be looking at the skin and looking for any type of changes. So I like to call this the mole patrol, where we're looking at things. And you want to remember the acronym ABCDE, okay? A is for asymmetry. If you see a mole or a freckle or a lesion, and it's symmetrical, it's round or it's even not round, but it's symmetrical on both sides, chances are more likely it is not a cancer. but it is something you want to keep an eye on, because what starts off as not a problem can eventually develop into a problem, which is why the monthly exam is so important. So looking at A, we're looking for asymmetry. B, we're looking for border irregularity. Again, look at the border of that. Is it nice and smooth, symmetrical, or does it seem to be irregular and jagged? Looking for C, color change or color variation. So has the color of that particular mole or lesion changed? Or it hasn't changed, but it's multiple colors. It's like a speckled type color in there. Those are red flags. Diameter, if it's over 6 millimeters, which is over a half a centimeter, it leads us to believe what's going on here, especially if it's getting bigger, if it's changed in size. And that leads us to E, for evolving. If something is growing or something is changing in appearance, any one of these A, B, C, D, E is a flag that, hey, I need to get this checked out a little bit more in depth. Does it mean they absolutely are going to have skin cancer? No, it doesn't mean that. But it's a red flag. It's, hey, I need to go get this checked. I need to figure out what's going on. So there's actually 3 main types of skin cancer. There's basal cell carcinoma, there's squamous cell carcinoma, and then malignant melanoma. So let's start with basal cell carcinoma, or BCC. This is actually the most prevalent type of skin cancer. It rarely causes death because it doesn't really extend beyond the skin. It really stays in the skin. You see it most likely on sun-exposed hands, face, neck, scalp, places that are exposed to UV light quite a bit. It typically appears as a small waxy nodule. It might be shiny or flat. It may even be a little discolored, gray or yellow, kind of like that pearly gray. And it's treated with surgical removal or sometimes medications. It can reoccur, so it's something that, again, as part of that mole patrol, we want to be watching for. Now, squamous cell carcinoma, or SCC, this is going to come from the epidermis. It comes from sun-damaged skin, or the other place that you see this is on the mouth and the lips, because it's associated with smoking and tobacco use. This can metastasize by blood or lymph tissue, and it's going to manifest as a rough, thickened, scaly type tumor. It might be asymptomatic, it just kind of looks funny, or sometimes they can be prone to bleeding. The border tends to be very wide, and it tends to look more inflammatory. Typically, we're going to treat this with surgical excision and possibly medications. Other things that we can do in relation to that, and again, remember, treatment is going to depend on the location, the type, and the depth of the tumor. So they might use radiation, they might use photodynamic therapy, where we're actually using UV rays to treat it. We might use a topical chemotherapeutic cream, Fluorosil 5-FU, which is part of your class prep for today, so we'll talk about that in class. But that's a medication that we can commonly use. We might use cryosurgery, which actually uses sub-freezing temperatures. It destroys the lesion. It's like a topical liquid nitrogen, and it causes a red swollen blister, and then the lesion falls off after about 3 weeks and new tissue will grow. We might use laser surgery that can actually cut, coagulate, and vaporize the diseased tissue. The micrographic surgery that they do, they're in the OR and they remove just very tiny layers of tissue. They look at it under the microscope. Oh, nope, it still looks like it has cancerous cells, so they take another layer. They'll look at it under the microscope. Still has cancerous cells, take another layer, and they'll keep following that process until they get a layer that's free of cancerous cells. With malignant melanoma, this is the most deadly form of skin cancer, and this is the one that metastasizes, and many times it is not diagnosed until it's stage 3 and stage 4. which is why that mole patrol and really looking at the skin closely and looking for changes is so important. This particular disorder arises from the melanocytes. Those are the cells that produce the melanin, and that's responsible for skin color. So other things that put people at risk are immunosuppression, and we will talk about this more when we get into the cancer unit in Unit 6. But essentially, a healthy immune system finds cells that look abnormal and destroys them many times before they turn into a cancer cell that can, reproduce and just cause havoc. So if we're suppressing the immune system, either through a medication, through a treatment, or through some other disease or disorder that causes the immune system to be suppressed, that's going to put them at higher risk for all types of cancers, including malignant melanoma. Another factor highly associated with melanoma, environmental hazards, UV rays, particularly Agent Orange. And I mention this because you do take care of a lot of older adult population, and a lot of the older adults you take care of may have served in Vietnam or over in Southeast Asia, and Agent Orange was a chemical that they used basically to destroy trees and various things over there for the troops to be able to move. Well, our troops were also exposed to this, and we're seeing the consequences of that as well. The other big risk factor is called dysplastic nevus. So this is a disorder where a patient has multiple, like just tons, multiple is not even a big enough word for it, just tons of atypical moles that are, more than 5 millimeters. They have irregular borders, they're various shades of color, and they tend to have them multiple areas of the body, like they have lots and lots of nevi. And if they actually have the dysplastic nevus syndrome, they are actually double the risk of developing malignant melanoma. Okay. So here are just some pictures of what malignant melanoma may look like. You can definitely see very asymmetrical things here. You can see irregular borders, some different variation in the colors, very dark, non-uniform color. The diameters are certainly bigger than a half a centimeter. And of course, looking at the evolving piece, we don't know what this patient looked like ahead of time, but as you're seeing changes, that's a big red flag. Malignant melanoma is diagnosed with an excisional biopsy. So again, they'll take a sample, look at it under the microscope, and go from there. Treatment is really going to depend on the site of the original tumor and the stage of the cancer. Again, we'll talk way more about cancer in Unit 6, but just understand for now, cancer is staged from 0 to 4. The higher the number, the more severe the cancer is, the more advanced the cancer is, the more it has spread. So treatment for this generally involves surgery. If it's metastasized, and malignant melanoma does tend to metastasize to the brain, they will often treat that with radiation. They will also typically use chemotherapy to treat any type of lymph node involvement as well.